My name is Dr. Gregory Curfman, and I'm the Interim Executive Editor of JAMA. In this JAMA interview, we'll be discussing the treatment of hypertension. And to address this important and common clinical problem, we're pleased to be joined by a leading expert on the subject. Dr. Robert Carey is a professor of medicine and Dean Emeritus of the School of Medicine at the University of Virginia. Dr. Carey is the lead author, along with his co-authors, Andrew Moran and Paul Welton, of a review article in the November 8th, 2022 issue of JAMA, titled The Treatment of Hypertension, a Review. Thank you very much for joining us, Dr. Carey.
Well, thank you, Dr. Curfman. It's a real pleasure to be here.
To get us started, Dr. Carey, I wonder if you could give our listeners a definition of hypertension, because this has been modified just within the past few years, and we'd like to be updated.
Yes. Well, it was updated in 2017 by the American College of Cardiology, American Heart Association Clinical Practice Guideline for high blood pressure in adults. The conclusion of that panel was that high blood pressure is any blood pressure value at or over 130/80 millimeters of mercury in adults who are less than age 65. And for those who are at or over age 65, the definition just relates to systolic blood pressure, and this would be a systolic blood pressure of 130 millimeters of mercury or more.
Now, I wonder if you could talk to us about the scope of the problem of hypertension in the U.S. and what are the clinical consequences of uncontrolled hypertension?
The Surgeon General issued a report a couple of years ago in which he stated that the world's greatest risk factor for cardiovascular disease is hypertension, and it was a call to action for hypertension control. So the prevalence of high blood pressure in the United States is about 44 to 49% of the general adult population in the United States. Using the American College of Cardiology, American Heart Association numbers that I just quoted of greater than or equal to 130/90, that encompasses about 116 million adults in the United States. Of course, on a worldwide basis, it's much greater, and as we see it today, there are more than 1 billion adults with high blood pressure. The issue for high blood pressure is that it is a risk factor, a major one, for cardiovascular disease and stroke. This applies to myocardial infarction and coronary artery disease, and also to heart failure, both with high and reduced ejection fraction, or normal and reduced ejection fraction, and also to stroke. Those are the major cardiovascular morbidity and mortality sources, but also high blood pressure dramatically increases the risk of chronic kidney disease and end-stage renal disease. And furthermore, it affects atherosclerosis throughout the body, including peripheral arterial disease, as well as renal vascular disease, so that blood pressure really has a tremendous effect if it is left uncontrolled. In addition, there have been some recent studies showing that high blood pressure has detrimental effects on cognitive function as individuals age. And so this is something that's serious, and we need to be able to measure blood pressure accurately in the office so that we can make the diagnosis of high blood pressure and initiate the proper treatment.
It's an extraordinary number of people who may be affected by hypertension and considerable morbidity and mortality related to it. In that light, how does the physician go about deciding whom to treat? What would be the pathway leading to treatment?
First of all, I think you could argue that all adults, whether they have normal or high blood pressure, should be engaged in lifestyle modification to optimize their lifestyle. But in terms of high blood pressure, we have several categories above normal blood pressure. We have a category called elevated blood pressure, which is 120 to 129 millimeters of mercury systolic over less than 80. And while previously this was thought of as a relatively benign classification, nowadays with the reclassification of blood pressure, elevated blood pressure is considered an increased risk state, hence the name. And so lifestyle modification should be initiated and continued for individuals with elevated blood pressure. And then we have the higher category of stage 1 hypertension, which is 130 to 139 over 80 to 89 millimeters of mercury. And again, we recommend lifestyle modification for this group. But then we decided that we needed to exert some way of identifying the people in the stage 1 hypertension category that have the highest cardiovascular risk, because treating them to reduce their absolute risk is most important. And so within this blood pressure category, 130 to 139 over 80 to 89, we recommend assessing cardiovascular risk. And either the patient has cardiovascular disease, in which case he or she is in a high-risk category, or the patient does not have cardiovascular disease. And then, if that's the case, one should measure atherosclerotic cardiovascular disease risk. One can do that with a simple app to the pooled cohort equations, which were published by the American College of Cardiology and are available on a telephone app or online. We recommend that a person with stage 1 hypertension who has a cardiovascular risk score that is greater than or equal to 10% risk for 10 years should be treated with antihypertensive agents, pharmacologic agents, in addition to lifestyle modification. But those that do not have elevated risk, they have less than a 10% risk score for 10 years, can be treated with lifestyle modification alone. And so that's how we separate out the patients that need pharmacological treatment. And when you get to stage 2 hypertension, which is greater than or equal to 140 over 90, we recommend that those individuals be started or initiated with 2 antihypertensive agents of different classes.
You've alluded several times now to lifestyle changes, and I wonder if we could begin our discussion of specific treatments with lifestyle, and if you could elaborate a little bit on what types of interventions you're referring to, and also comment about how effective lifestyle approaches are in controlling blood pressure.
Absolutely. Well, I like to think of lifestyle change as the cornerstone of antihypertensive therapy. It's something that everyone should be engaged in, and lifestyle modification is very effective. So when we say lifestyle changes, we mean several changes, including weight loss, especially in obese, overweight, or obese individuals, dietary sodium reduction, dietary potassium supplementation, whole dietary pattern, physical activity, and limitation of alcohol intake. So those are the lifestyle changes. And you asked how effective they are. So I'll give you some examples. A weight loss of 1 kilogram usually equates to a reduction of 1 millimeter of mercury in systolic blood pressure in hypertensive individuals. A reduction of 1 gram of sodium intake in the diet will reduce blood pressure by about 3 millimeters of mercury. Engaging in a healthy whole dietary pattern, such as the Mediterranean diet or the DASH diet, will reduce blood pressure by a minimum of 5 millimeters of mercury systolic. Physical activity is also effective in reducing blood pressure by about 5 millimeters of mercury, and this applies to both aerobic and anaerobic resistance exercise. Overall, if you look at all of the available lifestyle modifications that one can engage in, you can think of it as reducing blood pressure by a minimum of 5 millimeters of mercury, but these are at least partially additive. So when one adds weight loss, for example, to dietary sodium restriction, one can come close to doubling the reduction in blood pressure. Also, an important point is that lifestyle modification increases the effectiveness of antihypertensive drugs. And so it is very well worth doing lifestyle modification in people who are taking drugs. And I would argue that it is probably even more important to engage in nonpharmacologic therapy in people who are taking drugs.
Let's say that we've tried lifestyle changes and we haven't been fully successful in controlling blood pressure, and we have to turn to the pharmacological treatment of hypertension. And I wonder if you could specifically comment on the categories of drugs and talk also about the order in which you'd be thinking about prescribing antihypertensive agents.
Well, thank you. So my approach is that I always start by talking with the patient and trying to establish an agreement with the patient on the blood pressure goal to be achieved. And I think what this does is it helps engage the patient and motivate the patient, because in the process of that discussion, I am telling the patient what the risks are that we covered earlier for uncontrolled blood pressure. So once I establish that agreement with the patient, then I initiate first-line drug therapy. There are 3 classes of antihypertensive agents that fall into first-line classes. The first one is a calcium channel blocker. The second is an inhibitor of the renin-angiotensin system, either an ACE inhibitor or an angiotensin receptor blocker. And please note, these 2 classes should not be given together in the same patient. And then the third in this first-line drug category is a thiazide or thiazide-like diuretic. And this gives me a good chance to mention that the thiazide-like diuretics are longer acting and therefore control blood pressure over a greater span of the 24-hour day than do thiazide diuretics. And the 2 examples of drugs in this class are chlorthalidone or indapamide. I tend to favor starting patients on either chlorthalidone or indapamide if I'm going to use a diuretic. Then the approach, if you're starting one agent, is to bring the patient back to the office, at least for monthly blood pressure visits, until the blood pressure goal is achieved. And in the meantime, when the patient is at home, I ask the patient to engage in home blood pressure monitoring. This monitoring requires the patient to purchase a validated blood pressure cuff and get some instruction, which can be done by office staff, on how to take blood pressure accurately. And then I ask the patient to record those readings, either with a pencil and paper or digitally, and bring them back at the return visit 1 month later. And there's been an interesting study which shows that for home blood pressure monitoring, a minimum of 2 blood pressure readings in the morning and again in the evening for 3 days a week gives you enough blood pressure data to bring back to the doctor that one can make a useful assessment of home blood pressure readings in that way. and still not be overburdensome to the patient. And then it's important, I think, to use medications that will promote adherence if possible. We'll talk about this later, but adherence to antihypertensive drug therapy is a huge problem, and we need to try to prevent that right from the beginning. I try to use fixed dose combination pills if I'm using two drugs. And I try to use long-acting drugs, which all of the first-line agents are. And I try to use 90-day prescription refills rather than a shorter interval so that the patient won't be going to the pharmacy all the time. When the patient comes back, I have the blood pressure readings from home. I also assess the office blood pressure readings, which are generally higher. But I go mainly by the home blood pressure readings. And if the blood pressure is not at goal, then I would add another agent from a different class. For example, if I start the patient on a calcium channel blocker, I could add an ACE inhibitor or ARB. And I keep bringing the patient back and keep doing that until I have the patient on 3 drugs or the blood pressure is controlled below 130/80. If I'm having trouble in achieving goal or achieving blood pressure reduction with the antihypertensive therapy, I try to assess the social barriers of health and also non-adherence. But there are many barriers to patients taking their medications and achieving blood pressure control, from lack of insurance to difficulties at home to depression to anxiety and many others. So it's important to assess those barriers. And then I dose titrate the first-line agents up to a maximum. And at that point, if the patient is on agents from 3 different classes of antihypertensive agents and the blood pressure is still not controlled, that defines resistant hypertension. And there are several additional classes of antihypertensive agents that one can employ in addition to the first-line agents. And the first 2 that I usually go to are beta blockers. And beta blockers are good first-line agents. They're not as effective as our listed first-line agents in stroke prevention. But other than that, they're pretty good. So I use beta blockers. They're first-line in patients with heart failure and ischemic heart disease. The second class of agents that I usually use are alpha-1 adrenergic antagonists because they have few side effects and tend to be effective. And then when we get to the discussion of resistant hypertension, I'll bring in mineralocorticoid receptor antagonists into the discussion.
Well, you've brought us to resistant hypertension, and this has got to be the most difficult and most challenging aspect of the treatment of hypertension. And you've mentioned some valuable tips already about how you approach it. But I wonder if you have anything else you'd like to add about this. And in particular, do you think that there is a role now, or will there be in the future, a role for radiofrequency ablation in the treatment of resistant hypertension?
Yes, let me come back to that last. Resistant hypertension is an important problem. I mentioned earlier that non-adherence to medical therapy is also a big problem. And before labeling the patient as having resistant hypertension, one needs to make sure that they do not have non-adherence. In addition, you want to make sure that the patient does not have so-called white coat hypertension or the white coat effect, which is that the office blood pressure is higher than the blood pressure taken at home or by ambulatory blood pressure monitoring. That would not be classified as resistant hypertension. And then finally, just blood pressure measurement itself is important. I can't tell you the number of times that I myself have gone in to get a blood pressure check at an annual checkup, and the blood pressure cuff is slapped over my shirt sleeve, and I've got my legs crossed, and I'm slumped over. Those are no-nos for taking accurate blood pressure measurement. So one needs to familiarize themselves with that, and there's a nice little table in the ACC-AHA guideline from 2017 that tells you how to do that. Once you have made the diagnosis, though, of resistant hypertension, that is, the patient's on 3 antihypertensive agents, still has elevated blood pressure above goal, 130/80, and you've excluded the white coat effect, non-adherence, and you've excluded a faulty blood pressure measurement technique, then the chances are they have true resistant hypertension. And there are several steps that one needs to take in evaluating such a patient. The first is to identify and reverse any contributing lifestyle factors that you see. If the patient's overweight, if the patient is consuming a very high sodium intake, or not getting any physical activity, that should be identified and reversed if possible. And the second step is to discontinue and minimize interfering substances. And there are lots of interfering substances, but one of the most common is NSAID therapy for chronic pain or for chronic inflammation. NSAIDs should be discontinued because they are a big cause of resistant hypertension. Blood pressure can come back to normal or to being controlled after discontinuation. Also, it's interesting that this year, acetaminophen was also found in a randomized trial to increase blood pressure. So there are no commonly employed antihypertensive agents that don't have effects on blood pressure. Also, another common cause is hormone therapy, either oral contraceptives or postmenopausal hormone therapy. So these need to be checked and discontinued, among others. And then finally, secondary hypertension, the most common of which is primary aldosteronism, needs to be screened to rule out any contributing secondary cause. And this can be done with a plasma renin activity and aldosterone measurement. And then we get to the treatment of a patient once all of that is done. Once again, I'd like to emphasize switching the patient from a thiazide diuretic to a thiazide-like diuretic such as chlorothalidone or indapamide can often result in blood pressure control. And then the fourth add-on agent under these circumstances is mineralocorticoid receptor antagonist therapy with either spironolactone or eplerenone, which are the two approved steroidal MRAs available in the United States. That, again, will often dramatically reduce blood pressure, and especially in those hypertensive people with suppressed plasma renin activity, even though they don't have primary aldosteronism. So if the blood pressure goal is achieved, then the patient can be maintained and checked every 6 months. But if the blood pressure goal has still not been obtained, then I think it's important to reassess for drug adherence. The way to do that is either by self-questioning or administration of a questionnaire, or doing a pill count at the pharmacy, or getting pharmacy refill data, or doing electronic monitoring, which is a new method that's been used a lot and it's very effective, but it's not used much in practice. And that is where the pill bottle has an electronic device, and every time it's opened, it is checked. There's available also a more sophisticated system called the Proteus system, in which digital measurement can be made every time the pill goes into the gastrointestinal tract. A message from a tiny chip can be sent to a patch that then indicates drug ingestion. And then finally, drug assay by high-pressure liquid chromatography, mass spectroscopy, is available in most large medical centers now and can measure drugs specifically. So it's important to try to get the best measure that one can for adherence in the situation. And the two methods that are most quantitative and accurate are the electronic monitoring that I just described, and also drug measurement directly. And then if the patient is still having problems, there are accumulating data suggesting that renal denervation may be an option. And whereas at the time our guideline was written in 2017, it was really experimental and still is, but I think it's on the way to receiving approval for certain kinds of hypertension, particularly resistant hypertension. The effects are often dramatic. There's no issue, of course, with drug adherence, since the vast majority of the patients are able to discontinue antihypertensive drug therapy and have their blood pressure normalized. It's not always the case, but it does apply in a lot of patients. And then if one is still having problems, I recommend referring to a physician who does have expertise in controlling resistant hypertension. Almost all large academic centers have such individuals available.
Well, Dr. Carey, I want to thank you very much for your authoritative and illuminating discussion, for your insightful comments about this very important clinical problem. This episode was produced by Jesse McWhorters at the JAMA Network. The audio team here also includes Daniel Morrow, Shelley Steffens, Lisa Harden, Audrey Foreman, and Marilyn Frickeluk. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.